Breast cancer is an important medical and social problem in Romania, as it represents the most frequent malignancy in women and the number one cause of mortality by cancer in women. In my country, for the moment, late presentation is still a problem. Even if in the last few years, due to education, we don't see so frequently the large ulcerated tumors that we used to see, women still come in with palpable, usually quite large tumors. Lack of patient-oriented information and regional screening programs are some possible explanations for such late stage presentation. The treatment of those large tumors is much more resource intensive, both for the society and for the individual. One particular limitation and issue in this regard is radiotherapy. A recent analysis revealed that the equipment in Romania is outdated and insufficient. In fact, only 16 centers have high-energy radiotherapy machines, and the rest of the centers in the country, which served actually 22 million people, have only conventional radiotherapy machines. Access to medical treatment and drugs in particular improved over the last years. Patients have free access to most conventional chemotherapy and hormone therapy drugs. However, access to the most expensive targeted therapies such as trastuzumab or lapatinib is still limited. Due to resource constraints, there is a special mechanism or commission that grants access to trastuzumab, for instance, in Romania. As the number of patients that can receive the treatment is limited, there is a waiting list, and in fact, the patient has to wait sometimes several months to receive the approval for the drug, which evidently impacts on her prognosis. I believe that in Romania, and probably in most of the former Eastern European countries, the majority of the interventions needed for the early detection, diagnosis, treatment, and follow-up of patients are actually in place. However, what lacks is the coordinated interaction among the different providers. I believe that what is needed is to support the development of the dedicated multidisciplinary breast units that could take care in a coordinated fashion of these patients. There are a few centers that already work in this way, having access to all the multidisciplinary treatments and techniques needed in order to perform breast cancer treatment. However, the majority of breast cancer patients are treated in smaller centers where not all the elements exist to provide the multidisciplinary approach. And this leads to insufficient or delayed treatments in different phases of the treatment with implication for the patient prognosis. Here again, the model proposed by the BHGI could easily be used to identify which resources are lacking at a certain unit with the goal of improving the quality and timing of the treatment for those patients. I would say that the progress is slow, that the concept of breast units is poorly understood. Most cancer professionals, be it surgeons, medical oncologists, or radiotherapists in the smaller centers, treat all types of cancer, and they see this multidisciplinary unit as a limitation. The health authorities do not support this initiative yet, but I hope that in the future, the example of the few centers that are organized in this way, taking the example of the units in other parts of Europe and in fact in the United States, will probably bring the change, because other centers will see that the results obtained for the patients are better in these integrated centers. To make a point, in Europe, the European Parliament had a resolution recommending that all breast cancer patients should be treated in such multidisciplinary units, because in 2011 is not allowed anymore to have the medical decision for a breast cancer patient taken by just one individual. Looking back at the last 10 years, and there are 9 years now since the first meeting of the BHGI in Seattle, I believe that access to drugs has notably improved. At the first meeting in 2002, I was describing how we used to have a fixed and small budget for chemotherapy drugs for each doctor, and we had to order our medication for each month. At that time, we had to decide to treat 20 patients with the least expensive drug or chemotherapy regimen such as CMF, or to treat only 5 patients with the more expensive anthracyclines. The situation now is that due to better financing, we still work on a fixed budget, but this increased and corroborated with the decrease in cost of the drugs, that the majority of drugs went generic, access of patients to treatment improved dramatically. As I mentioned before, only the most expensive targeted therapies such as monoclonal antibodies and tyrosine kinase inhibitors are still with limited access for the patients. I strongly believe that the model of comprehensive, incremental, resource-stratified model of management of breast cancer proposed by the BHGI is a viable and practical one. The concept of making best use of the resources available, promoted by our group way before the raising costs of healthcare prompted everyone to think about cost effectiveness, is a very pragmatic and an actual concept. Participating in the team effort of generating the BHGI recommendations helped me change the way I approach breast cancer management in general. It definitely helped me better organize my department, but on a larger scale, I hope that the work we are doing through the learning laboratories such as the one in Ghana and other locations throughout the world will help make a change in the way breast cancer patients are treated throughout the world where resources are limited.